Hey everyone. We are 1 minute from noon, so might as well get started. I'm sure people will join us. As usual, this will be put on Facebook Live, as well as recorded and uploaded on YouTube later on. So if you can't make this the noon talk, I know it's kind of an awkward time for a lot of folks. You can watch it later on either one of those forums. All right. So those of you who don't know me, I think we have a lot of new folks here. My name is Han Kim. I am professor of public health at Westminster College. I'm an epidemiologist by training, and I've been doing this brown bag for a year and a half almost. So as long as the COVID pandemic has been happening, I've been doing this pretty much every week. I've had a couple of weeks that I've missed, but I've been usually doing this every week. For the duration. So I think it's been useful to go over the numbers for folks, go over the recent news, and just kind of hopefully, give my take on some of the sometimes very complex and very convoluted news that's out there in regards to the pandemic. So there's a ton of stuff to go over. One of the things I want to do today is kind of start with a brief epi lesson. So a little bit of an epidemiology lesson, because I think there's a lot of confusion here because especially with vaccines, we've been talking about efficacy of the vaccine versus infection versus disease versus hospitalization versus death. What does that all mean? And there's different numbers for each of those metrics. And there are differences. When we talk about vaccine effectiveness there's a difference between effectiveness and efficacy, but there's also a difference between effectiveness against infection, effectiveness against symptoms, against hospitalizations, against disease. And all those numbers are going to be different. So I want to go over a little bit of really basic virology. This is super duper basic. So those of you who already know this, I apologize, but I think it's worth kind of reviewing the differences between infection, exposed, infection, and disease. So this is a very simplified virus to disease pathway. So very simple. So in terms of trying to frame vaccine efficacy, testing, the progression of viral diseases, I think this is a nice little model. So viruses, of course, are just pieces of genetic material, RNA or DNA, surrounded by a protein coat. That's all they are. They can't do anything outside of a cell. So with that, when it's not inside of a cell, it really can't do anything. It enters a cell through various pathways. With SARS-CoV-2, it enters through the ACE2 receptors. So these are receptors that certain genes express on the cell wall. And the spike protein is like a little key that fits into the ACE2 receptor and allows the virus to enter the cell. Once inside of a cell, that's where the virus starts to do damage. So it hijacks the mechanisms of the cell to create copies of itself. That's all a virus does. Okay. So outside of the cell, it really can't do anything. It can only do damage once it enters the cell, start replicating, and then those viruses then goes out, finds other cells, and the process repeats itself. Okay. So that's when you have increasing what we call viral load, which is the number of virus circulating, and greater increase. And as viral load increases, the risk of transmission increases because you have more viruses. That means you can shed more viruses and you can transmit it to other hosts, other people. And also, as viral load increases, typically symptoms and signs and disease progresses. So that's the basics of a virus. So all the virus wants to do is replicate. That's all it wants to do. Okay. It wants to get into a cell, make copies of itself, and just repeat the process. All right. So let's talk about exposure, infection, and disease. So these are three stages going from a virus to disease. Okay. It starts with exposure, which sometimes leads to infection, which sometimes lead to disease. I need to emphasize that not all exposure leads to infection. Not all infection leads to disease. Okay. So what is exposure? Well, exposure is when there's a potential for the host to have the virus enter their bodies and enter the cells. So there is circulating virus in the air, or, with a fecal oral disease, maybe it's on your hands. If it's foodborne, it's in food. So you're exposed to the virus. It may have actually entered your body. Okay, so you may have breathed it in, you may have ingested it, but it hasn't yet entered the cells. Okay, so at that point, the virus can't do anything. Okay, the virus isn't replicating, so it doesn't do anything. So a lot of folks will be exposed, and we're probably being exposed more than we think, especially with something as transmissible as Delta. But as long as it doesn't enter your cells, it can't do anything. Okay, now it can, because it's not entering your cells, it can't cause signs and symptoms, it can't cause disease. Okay, it cannot cause transmission. Transmission only occurs after the virus starts replicating inside your body and produces enough virus so that you can shed virus. Okay, now it can lead to infection. Okay, so once those cells enter once those viruses enter the cells, it can actually lead to infection. Okay, so infection. So what is infection? So you have to be exposed to be infected. Infection is the next step. So exposure has occurred. So there's viruses in your environment or inside your body, and they have entered your cells. Okay, once inside your cells, it is starting to replicate. So the number of viruses is increasing in your body exponentially as it hijacks more and more of your cells and produces more and more copies of itself. Okay, it can cause transmission. So infection can cause transmission, usually after viral load increases to a certain point. So it doesn't happen immediately. Oftentimes, it takes sometimes a few days or a few weeks for your body to produce enough virus for it to shed and cause transmission. That is highly dependent on the disease. Okay, some diseases work very slowly. For example, TB, it's not viral, I apologize, I know it's bacterial, but it takes a while for you to start shedding virus. Whereas some other diseases, you're shedding virus almost fairly soon after infection occurs. Okay, and if you get enough of a viral load, it can lead to disease. So what is disease? So disease is when, okay, you're infected, viruses enter the cells, it's replicating at a high level, and typically because the viral load is so high and so many of your cells have been hijacked, you're starting to show signs and symptoms of the disease: coughing, respiratory distress, fever, et cetera, et cetera. So this is typically when you know you have a disease. A lot of times, if you have infection but no symptoms, you have no idea you have the disease. You won't get tested. A lot of folks will get infected. It never leads to disease. People have no idea they even had the disease. Okay, so, but once the viral load gets to a certain level, and that load, it depends on a whole host of factors, you start showing signs and symptoms. And this is when you first realize, I'm sick. And this is when you may go get tested, may start treating the symptoms, and so on. And at this point, transmission does occur as well, because oftentimes you are shedding. But a lot of times, if you are sick and you're staying at home, in some ways, transmission actually is reduced because you realize you're sick and you take care of yourself. You might treat the symptoms, which might reduce transmission, and you might isolate yourself, which might reduce transmission. In reality, most transmission occurs during the infection stage, when you're asymptomatic, when you have no idea you're shedding virus, and therefore you're not taking precautions to prevent transmission. So this is very simple, and I'll talk about some of the assumptions we make and some of the problems with this model in a bit. So from a public health and clinical standpoint, there are 4 main points where we can actually prevent disease from occurring. We can prevent exposure, we can prevent infection, we can prevent disease, or we can treat the disease. And all 4 are valid ways to deal with diseases, infectious diseases, at different points in its life cycle. So prevent exposure, prevent infection, or prevent exposure from turning into infection, prevent infection from turning into disease, and prevent disease from getting worse. So let's talk about each of these. So preventing exposure is basically preventing circulating viruses in the environment from entering your body, okay? or preventing the virus from circulating in the first place, right? The main tool we have for this is behavior change. There's really no vaccine for or anything like that. So it's behavior change. So it is isolating. It is mask wearing. It is isolation. Well, not so much mask wearing, but isolation, restrictions. Those are the main tools for preventing exposure, okay? Okay, social distancing, hygiene, quarantine, restrictions. Those are all valid tools to prevent virus from circulating or from in the first place, okay? The next step is preventing infection. So if you're exposed, is there a way to actually prevent those viruses from entering your cells? Okay, so it's preventing that exposure. The virus may be outside of your body or in your body. And how do we prevent it from causing infection? Well, behavior change still works here, okay? Masking and hygiene in particular. So if you are in an environment that you know virus is circulating, a mask may work well, or hygiene, okay? So those are ways to prevent exposure from becoming infection, okay? It's not quite as effective at this point. What can be effective here is this is where vaccination comes into play, okay? There are vaccines that can prevent exposure from turning to infection, okay? It's called sterilizing immunity, and this is kind of the gold standard for vaccines. And it's relatively rare, actually. Not too many vaccines cause sterilizing immunity. So sterilizing immunity means that the vaccine actually prevents, or your immune system after vaccinated actually prevents the viruses from entering the cells in the first place. And they use what's called neutralizing antibodies to do that. If it does that, the viruses don't enter the cells, infection cannot occur. So that is the gold standard. There are a few vaccines that do this. For example, the HPV vaccine, the smallpox vaccine, are thought to cause sterilizing immunity. Okay, so with vaccines that cause sterilizing immunity, if you're vaccinated and the vaccine is effective in you, you can't spread disease. Okay, so that's one metric. So we can actually determine, okay, how effective is a vaccine at preventing infection? And to test that, what we would have to do is do a clinical trial, and the endpoint would be infection. So for an asymptomatic disease like COVID, that means we would have to test everyone in the study probably every week or so for infection. Okay, so just as an FYI, none of the clinical trials did that. They asked subjects to call them and get tested only if they became symptomatic. Okay, so that is infection. So how good is a vaccine at preventing infection, preventing infection from taking place? So that's one metric. Now, preventing disease. So how do I prevent infection from progressing to disease? This is where behavior change can still play a role, okay? Masking, for example, hygiene, social distancing, okay? You can still, that can work. But really, this is where the bulk of vaccination works, okay? A lot of vaccines, if they don't cause sterilizing immunity, well, the next best thing is preventing infection from progressing to disease and serious disease, okay? So vaccines, including all of the COVID vaccines, does most of its work at this point, preventing infection from progressing to disease. Okay, so, or prior infection. I forgot to mention prior infection can also do this as well. Okay, so this is a slightly different metric. So this is when you may ask your study subjects to report symptoms and signs, okay? So usually, well, I'll get to that in a second, actually. And then, of course, there's treating disease. Okay, so you have disease. Can I treat this disease so that it doesn't progress to more serious disease, okay? So this, of course, this is where clinical care comes into play. Reducing symptoms, reducing signs can actually limit transmission, limit viral load, and can limit the disease from progressing. This is where vaccination also helps, okay? Vaccination is very effective at, even if you do get symptoms, the vaccine is still effective at limiting the damage so that it doesn't progress to serious disease and death. In fact, the COVID vaccines are extremely effective at doing that. Okay, so for vaccines, so as the disease progresses, your viral load progresses. So from exposure to infection to disease, oftentimes the main driver of that progression is increasing viral load, meaning the number of viruses circulating inside of you increases. Okay, but also as the disease progresses, the vaccine becomes increasingly effective. So vaccine effectiveness at preventing serious disease is usually much higher than preventing infection. Okay, so when you see, okay, what is the effectiveness against infection? Usually that number is going to be a lot lower. Against serious disease, typically it's much, much, much higher. And I think this is part of the problem with how we're communicating effectiveness of these vaccines, because some people use the metric preventing infection. How good are these vaccines at preventing infection? And indications are they can prevent infection. In fact, they are good at preventing infection, but maybe not quite as good as we thought. But they are still really good at preventing serious disease. That's for certain, and preventing death. Okay, so we're looking at very different matrices for effectiveness of vaccines. Okay, is it good at preventing infection? What's the effectiveness against infection? What's the effectiveness against disease? What's the effectiveness against serious disease? So there's a lot of different numbers that kind of tell you different things about that vaccine, okay? And then finally, and this is the other factor at play here, and that's testing. So you have an increasing chance of positive test as your viral load increases. So that makes sense. The PCR test, the reverse transcriptase PCR test, try to detect fragments of genetic material unique to SARS-CoV-2. So the more viruses circulating in the body, the more likely you're going to test positive. The other point that I want to make here is that infection, the only way to determine if someone has infection is testing. If you have infection, but you don't have symptoms, the only way to determine that is testing. And like I said, the clinical trials for the vaccines, none of them use infection as the metrics for effectiveness. They use symptomatic disease. Okay, so they didn't really, if they tested all the subjects every week, for SARS-CoV-2 with a PCR test, they could have checked for infection. But as it is, they probably got a ton of infection in their subjects. They never got symptoms. They never reported it. So the effectiveness that are published by Pfizer, by Moderna, by Johnson & Johnson, by AstraZeneca are all based on symptomatic disease. Okay. And again, effectiveness against infection is always going to be lower than effectiveness against disease, which is going to be lower than effectiveness against serious disease, which is going to be lower than effectiveness against death. Okay, so I just needed to clarify this because I think there's a lot of confusion about that. Now, like I mentioned before, this is not, it's not stages. It is much more of a continuum, okay? So the line between infection and disease can vary quite a bit because people have signs and symptoms at different times. People have more tolerance for certain signs and symptoms and so on. So it's more like a continuum. I think the other confusion that people have is that when we talk about infection, we talk about symptomatic versus asymptomatic infection. To me, I'd like to clarify this and say infection is just infection. Disease is when you have symptoms and have infection. Okay, but because we don't have this standardized way of talking about it, it's just led to a lot of confusion. So I want to clarify that because a lot of the stuff we're going to talk about later on is the rationale behind the CDC's reversal on their mask policy that everyone, including the vaccinated, wear masks. What's the rationale? And I want to share some of the, quite honestly, very messy data around that decision. I don't envy the CDC because they're dealing with a brand new disease, which is changing constantly. And of course, you have to change as conditions change, but a lot of people simply conclude that the CDC is just being wishy-washy. And that's unfortunate because this disease is changing. It's going to change. That's going to require changes in policy. All right. So I just want to go over through that little basic epi. I occasionally give a little basic epi information, but I wanted to go over that because hopefully that'll clarify some of the debate and clarify some of the really kind of confusing discussions that are happening out there right now, even amongst scientists, even amongst public health folks. There's a lot of confusion. And I think if we can kind of just keep that terminology straight, I think it would clarify a lot of things. Okay. So I want to go over the numbers. So I typically go over global, national, and local numbers. So I want to go over this fairly quickly because things haven't quite changed. It's gotten worse, but it hasn't really changed too much. So here's the global numbers. Most of the graphs are from a few sites. New York Times and Washington Post have some great graphics, so I'm using their graphics, but they're all based on the same data. I also use a site called Our World in Data, which has, again, uses the same data and has a wonderful interface so that if you're curious to explore the raw data, it gives you a wonderful interface to do. So globally, we are still in our third surge, global surge, fourth global surge, depending on what your definition of surge is. I'll say it's the fourth global surge, and it is continuing to increase. We are now at about 600,000 cases per day with a total of 200 million. We do know that that's probably a gross underestimate, okay? Deaths are about 9,000, 10,000 a day. Like, that's probably even a worse underestimate, okay? And that 4.2 million deaths total, I would say that's an underestimate by a factor of at least 10. That's how bad these numbers are. And just trying to determine, what is a COVID-related death it's very difficult. So anyways, so cases are increasing. Deaths are kind of steady. It's actually dipped a little bit. So that's good news. But again, keep in mind, that's an underestimate. The hotspots right now are the US. We are a hotspot. In fact, we have taken over as the #1 country in terms of new cases per day. Western Europe is still struggling, although the UK is showing some really interesting numbers. I'll talk about that. African numbers are getting very, very concerning. They are very, very concerning, particularly in the southern part of the continent, but also in northern Africa. The center, East and West Africa, we think the numbers are really underestimated. And so it's hard to grasp the magnitude of this, of the impact of Delta on Africa. The Middle East is surging, Southeast Asia is surging, as well as parts of Central Asia. Okay, so here are our confirmed cases. This is Our World in Data. So Southeast Asia, the US, South America is actually doing better. Not at a level where things are back to normal, obviously, but they're doing better than they were. For the longest time, South America has been struggling mightily. So by continent, right now, Asia, in terms of count, so these are new cases per day. Asia is at about 250,000 cases per day, mostly driven by the Middle East and Southeast Asia. North America is now taken over #2 over Europe. Europe has dipped a little bit because of the declines in the UK. South America, like I said, is slowly going down. For the longest time, they were #1, but things are getting better there slowly. Africa, again, they're going up, but we think those numbers are really, really underestimated. And then Australia is still actually struggling a bit with COVID right now. We'll talk about that in a second. So we have, for the longest time, we were 4th or 5th on this list. Now we have rocketed back to #1. We're close to 100,000 cases per day. India's 2, Indonesia 3rd, Brazil 4th, but we are more than twice the second of that of India right now. So things are bad here. Things are definitely bad. But again, it's going to vary by the region of the country. But you can see a lot of European countries and Southeast Asian countries, along with a few African countries here. And what's really sad is that countries that have been doing such a good job of controlling the pandemic are now on this list. For example, Japan, Vietnam. Those countries were doing a phenomenal job of controlling COVID, and they just ran out of steam, essentially. Thailand as well. Thailand is going through a serious surge. In terms of per capita, See, South America still kind of leads the way, as well as Western Europe and parts of Africa and Southeast Asia. You can see Malaysia in particular has some really, really high numbers. North America is from a per capita, so per million new cases per million people, North America is now number one. South America was number one for the longest time. Now we have taken over. So that's mostly driven by the US. Canada's numbers are looking pretty good. Our numbers, not so much. Europe is second, South America is now third. Asia is increasing slowly. Same with Australia, New Zealand, and then Africa. In terms of countries, so the first few countries are, well, Fiji is a very small country, of course, in the South Pacific. Cuba is still struggling, as well as Botswana. Georgia in the Caucasus Mountains, not Georgia state, but Georgia over by Turkey and Russia, has been struggling for a while now. They've had some really high per capita rates. Cyprus, Malaysia, which is driving the Asian numbers, Eswatini. So you're seeing a lot of African countries here, which is really, really, really concerning. These are countries that just cannot handle a large number of positive cases. Already the hospitals are overwhelmed. They've run out of oxygen. They just don't have the clinical resources to deal with a large number of symptomatic cases. And so you're going to have really high mortality, unfortunately. So you're seeing a lot of African countries here, as well as European countries. Europe's going through another surge. What's also concerning is that a lot of these countries have high levels of vaccination. For example, you see Israel here, the UK, Spain, Cuba. A lot of these countries have really high levels of vaccination, yet they are still seeing a surge. And that kind of hints to the power of the Delta. In terms of changes, you see that the changes in North America, parts of Africa, Asia. Good news is that South Asia is doing much better since the horrific surge in India just a few weeks ago. And South America is slowly getting better and better. So that's the good news. It's pretty much bad news everywhere else. So in terms of changes in in the number of cases, Niger, Ecuador has seen a little bit of a surge, which is concerning, given what I just said about South America. Kosovo, so a lot of African countries here seeing big surges, as well as Eastern Europe. Africa and Eastern Europe seems to be kind of dominating this list. So just these countries, Delta is so transmissible. I doubt any of these countries are going to be able to escape a significant surge due to Delta. Again, given what happened in the UK, one of the most vaccinated countries in the world, and they still saw a horrific rise in COVID. Niger has very few people vaccinated. So it's definitely a huge concern right now in the global South. So just in specific regions, I'll just go over this very quickly. We'll talk about the US numbers. Canada is starting to show a slight uptick. Again, they have high degrees of vaccination. They have better vaccination rates than the US does now. Significantly so. But a lot of the Canadians are only vaccinated with one dose. And what we discover about Delta, of course, is that one dose is very, very ineffective. You really got to have two doses. So Canada is starting to show signs of a little bit of a surge. We'll see how bad it gets, given that Canada does have a much higher level of vaccination than we do. In the Caribbean and Central America, really, Cuba's really struggling, really struggling. Mexico numbers are going up, Guatemala, Honduras as well. Good news, Panama and Costa Rica seems to be kind of going down. And I don't know about the numbers in Haiti, given the political unrest there, how reliable those numbers are. Dominican Republic numbers are okay right now. Again, considering the lack of medical resources in countries like Dominican Republic and Haiti, they just can't handle these surges very well. Overall good news, like I mentioned, with the exception of Ecuador, which has seen a little bit of a spike, but not significantly. Most of the countries in South America have seen decline. So that's really good news, because these are countries that have struggled throughout the pandemic with some horrifically high numbers and a lot of death. On the flip side, Southern Africa is struggling, as with Eswatini, Botswana. Luckily, the Namibian surge is abating because they had some really bad numbers, and they're being hit hard right now with a lot of deaths right now. Again, these are poor countries that just do not have the clinical resources to deal with a large number of symptomatic cases. South Africa is kind of up and down. Looks like they're a bit of an upswing. Lesotho is seeing a little bit of an increase as well. So as far as East Africa, Rwanda, which has a slightly better public health infrastructure, so they do a lot more testing. It's probably why Rwanda's numbers are high. I can't imagine Rwanda's numbers at those high levels and Kenya and Uganda at those lower levels. So I think a lot of these numbers are grossly underestimated due to lack of testing and just due to a lack of data infrastructure. Interesting, Tanzania finally started to see an upstick. Those of you who don't know, Tanzania's president for the longest time denied COVID even existed, refused to do anything about it. Since then, they've had, we don't know how bad it's been in Tanzania because they just refused to report it. But they've since relented. There's a new president that says, well, maybe COVID is a bad thing. So we'll see. We'll see. The politicization of COVID is just, it's global, unfortunately. It is global. East Africa, West Africa is struggling. Mauritania, Senegal, Gambia, pretty high numbers. Now, keep in mind, the x-axis isn't that high. Again, I think these numbers are really, really underestimated, though. I really do. I think they're much higher in real life. It could be also that these are much younger countries, so most of these folks are probably asymptomatic. And then North Africa, Morocco is seeing a bit of a surge. Tunisia's numbers have since gone down. Nothing much happening in Egypt. So that's kind of the situation. In Africa, the Middle East, Israel now has a higher per capita rate than Iraq, Kuwait, Lebanon, all these other countries. So that's really highly concerning, given that Israel was a significant proportion of Israel is vaccinated with Pfizer, the most effective mRNA vaccine. So it's a little bit of a concern. I mentioned Central Asia, Azerbaijan, Turkey seeing a surge. Mongolia seems to be settling down now after a horrific surge. Iran, Kazakhstan has seen surges. So again, driven mostly by Delta. East Asia is doing, South Asia is doing mostly okay. Sri Lanka is seeing a bit of a surge, as well as Bangladesh and Nepal. So that's concerning given some of the horrific numbers they had just a few weeks ago. But right now, India is settled down, but at a fairly high level, though. And they're still having issues in India, but not to the degree they had just a few weeks ago. Bhutan continues to do well. Southeast Asia, the story is, these are countries that did extraordinarily well, given the lack of resources, just utilizing very standard public health measures. Again, you can't hold on forever with social distancing, mask wearing, isolation. Those are tools that work short term. You cannot expect a population to do that for a year and a half. Without vaccines, those previous tools will break down. And I believe that is what's happening in these countries. You look at Thailand's history, Malaysia's, they've been doing so well until fairly recently. Combine that with Delta, and you have some horrific increases in places like Thailand, Malaysia. Indonesia seems to have settled down a bit, but their hospitals are overwhelmed. Myanmar, Philippines, Laos, Cambodia, all seeing increases. Japan's numbers. Again, keep in mind the x-axis is not nearly as bad. So we're talking about 80 per million, which is, some of these other countries, they're at 800 per million. So keep that in mind, but still that graph is going straight up. And, there's this thing called the Olympics in Japan. And their vaccination rates are abysmally low. And I'm not going to get into my editorial about the Olympics and Japan's preparation or lack thereof for the Olympics during a pandemic. But anyways, Taiwan had a bit of a surge, got really good control over it. South Korea saw a little bit of a surge. They got control over it, and they're going down. I know South Korea and Taiwan's vaccination programs are a little bit more robust than Japan's. China, the data coming out of China, we do know they have surges of Delta in large cities like Wuhan, Nanjing, Chongqing. We just don't know how big they are because they're not sharing the data with us. They are, but there's some serious lockdowns, serious testing protocols being implemented to prevent these cities from prevent it from getting too bad in those cities. We just don't know how big they are. So things are not completely quiet in China either. That's the thing about Delta, given that it's so transmissible. Australia's numbers, again, the x-axis, these are very low numbers, but for a country that had almost zero domestic cases, this is concern. So again, this was because someone slipped through their very tight travel restrictions, went into Sydney, and boom, it's all it took, especially with Delta. It's all it took is one person. This is why I say those tools work for a little while. However, they will break down. You've got to vaccinate. And for wealthy countries like Australia, Japan, Taiwan, they have no excuse not to vaccinate. They could afford it. They could have jumped right in line to get the vaccines. They didn't. And this is the result. Western Europe, France, Ireland saw increases. Netherlands saw a spike and then is declining. The UK's decline, curious decline, seems to have stopped. And it looks like it's going back up. We'll talk about that in a second, because it's really, really curious what's going on. And the UK's experience could really tell us a lot about what we can expect in the next few months, okay? Germany's numbers are still quite good. Germany's done an admirable job throughout this pandemic. Of course, Germany has a very robust public health system. Then finally, Eastern Europe. Things are relatively quiet, but you're seeing some surges in the Baltic states, particularly Estonia and Lithuania, as well as some countries in Eastern Europe, Bulgaria, Bosnia. Things are still quiet in Czech Republic and Slovakia. Greece is kind of leveled off. I don't know how much of that is that, Greece is, of course, having issues with wildfires. I don't know how that's affecting reporting, if this is truly a plateau or they're just not testing because, well, they have other priorities. But things are relatively quiet so far in East Asia, in Eastern Europe. Russia's curious. Their numbers, I can't really say are super reliable. They're having serious issues with lack of trust in public institutions, lack of trust in the vaccines. So they're just stuck at this very high level. They're not seeing huge peaks and valleys. They're just seeing a relatively high level of constant cases. So let's talk about the UK real quick. Now, we saw this huge, horrific increase in the UK, almost matching the peaks that it had over the winter of 2020, of 21. God, I can't even say that. So, and this is a country that has approaching 70% of the total population vaccinated. Really robust healthcare system. And so this was really concerning. This was all driven by Delta. It kind of told us, okay, Delta is serious. This is something that is highly transmissible, because even in a highly vaccinated country like the UK, we're seeing this huge surge. And then right at the peak, Boris Johnson announced this is Freedom Day, and we're gonna go through with Freedom Day, meaning all restrictions are removed. And a lot of epidemiologists in the UK said, oh my God, this is gonna be bad. And then boom, egg in their face, because all of a sudden the numbers just cratered. They just started to go down significantly. And a lot of epidemiologists, we're just thinking, what's going on? We look like a fool, and Boris Johnson looks like he's right. And well, there's a lot of explanations. I think there's some really interesting viable explanations for this increase, and that now we are expecting for that big decrease, now we're expecting an increase again. One is, and I think this shouldn't be discounted. Well, number one, schools in the UK are on holiday. hot weather, but the real driver may be soccer. She's like, well, what's soccer? Well, Euro Cup, big deal in the UK and Europe because, well, England and Scotland qualified and they did really well in Euro Cup. And soccer is a religion, of course, in Great Britain. So huge number of people going to pubs, going to bars, cheering, yelling, screaming, close contact, lots of transmission. Could that have explained the increase? And then Euro Cup's over, everybody went back home, and then you started to decline. Now, there's some interesting features of this increase that may give some credence to this theory. One is the spike is mostly in young men, way more men than women, particularly younger men. Now, that makes sense given that they're less likely to be vaccinated, but young women are just as likely to be not vaccinated either. What's the explanation? Well, young men tend to be avid soccer fans. Once they went home, transmission stopped and you saw a decline. Another explanation, another data point that explains this, and this is interesting too. Scotland was also in Euro Cup. They got knocked out earlier. So the Scottish fans went home earlier. And so Scotland's decline actually was earlier than the UK's decline. Some interesting data points that may support how something is innocuous like Euro Cup, just a sporting event, can act as a super spreading event. And that's the big concern with the Olympics, of course. We saw this in the US, Sturgis. And a lot of epidemiologists still think Sturgis really drove those horrific numbers in the upper Midwest and the Plain States, and particularly the Dakotas. Remember how bad the numbers were in the Dakotas. Sturgis. By the way, this week, Sturgis. Motorcyclists from all over the country are heading there right now. Right now, they have really low numbers. They also have very low vaccination rates in Sturgis. And, not to generalize, but folks who go to Sturgis are less likely to be vaccinated or less likely to adhere to mask mandates or socially distance. I mean, don't get me wrong, I'm a motorcyclist, avid motorcyclist, but then again, I'm a motorcyclist who has no interest in going to Sturgis. It's not my thing. Don't have a Harley. I think they're kind of obnoxious. So yeah, so we'll see. So the power of these events as super spreader events, they do have a lot of potential to be super spreader events. So a lot of people were asking me, so did UK reach herd immunity? I don't think so. They're only at about 70%. They still haven't vaccinated kids under 12, like the US. So no, I don't think so. In fact, I don't think they've vaccinated anybody under 18. In fact, I don't think the UK approved the vaccines for younger kids, or they wanted to prioritize older folks who are more at risk. So they didn't want to approve it for younger kids because they wanted to allocate those vaccines for people who are at higher risk than children. In fact, that's one of the criticisms of our approval for 12 to 15-year-olds is that, well, they're not at risk. We should allocate the vaccines for people who are much higher risk. Of course, that point is moot because we're swimming in vaccines now, literally. Okay, so that's the UK. So really some curious things, but I think now, if Freedom Day is going to have an effect, and Freedom Day, from everything I understood, everybody went out. They hit the pubs, they went restaurants, et cetera, et cetera. Everything's back to normal in the UK. If we're going to see a surge from that, this happened about a week and a half ago. This is when we would start seeing the surge. And guess what? Looks like the numbers are making an abrupt increase again. So as much as we'd like to see the UK succeed in thinking, oh, hey, this Delta surge is going to be temporary, it's going to go down, I don't think so. And that is the positive tests. So much lower test positivity in the UK because they test a lot more. They test a lot more in the UK than we do, of course. And that's starting to have a little bit of an uptick up too. So these are my observations globally. You can read those. I think I kind of went over them already. Yeah, overall, it's not good. We're not in a good place globally. With a few exceptions, numbers are increasing worldwide. South America may be the bright spot, but again, it's not like they're down at a very low level. They're just down from their previously incredibly high levels. So we can't rest on our laurels. And South America has shown that their numbers fluctuate quite a bit. As far as deaths, we are now past 4 million. I would say at least multiply that by 5 to 10 times for the true global death count. We may not really know that for years until we can actually collate this data. We're now seeing an uptick of deaths per day, close to 10,000 deaths a day. So we were declining for a while. We were down to about 8,000, but it looks like it's increasing again. And I anticipate this to increase. That surge, remember, death is a lagging indicator. Got to wait for about a month after a surge in cases to see a surge in deaths. And I think globally, it's going to be very different. So in countries that see a surge, that have high degrees of vaccination, you're not going to see a surge in death, a significant surge in death. You might see a little bit of a surge, but it won't be that big because the vaccinations focus typically on those with greatest risk of death, typically seniors. However, in countries with little or no vaccination, you're still going to see horrific death numbers. And that's what we're seeing in places like Africa, Indonesia, in countries that have not been able to get their hands on vaccines. So Indonesia is really kind of driving the deaths right now. Even though they saw a decline in cases, again, death is a lagging indicator. So Asia, in terms of deaths, is number one, over 4,000 deaths a day. South American numbers are declining, so that's really good news. Europe, North America, and Africa are all seeing slight increases. Again, I don't anticipate Europe and North American numbers to get very high because most countries in Europe and North America are highly vaccinated, or at least they vaccinated their seniors, the most at risk for death. However, Africa numbers one thing Africa has going for it is that it's a very young continent. So that's going to keep the deaths at a lower level. But I'm still anticipating some really horrific death numbers because working against that, of course, is just lack of clinical resources. There are countries just don't even have oxygen. So in terms of daily deaths, Indonesia, Brazil, Russia, India, South Africa, US is now 5th. Again, I don't anticipate our numbers to get that high because we've done a good job vaccinating our most at-risk population. Then Mexico, Myanmar, and you can see the list here. In terms of deaths per million, South America still leads the list. Indonesia, southern part of Africa, Russia. You can see South America is still the number one in terms of deaths per capita. It is going in the right direction, but they are still two times higher than North America. By the way, North America's number now 2nd in deaths per capita, then Europe, Asia, Africa, and Oceania. Tunisia, 18. That's a really high number. 18 deaths per million people. That's really horrifically high. Namibia has gone down a bit. They were up there as well, but it's gone down. So you can see, you look at this list, it's almost all poor countries. Okay, Tunisia, Namibia, Botswana, South Africa, Fiji, Ecuador, Georgia, Paraguay. So, which makes sense, again, given deaths and lack of clinical resources, and also lack of vaccinations. Changes in deaths, Africa, Asia, Africa, North America, particularly the US, and Europe are seeing increases. Again, pretty much improvements in South America, so that is good news. Okay, and then as far as changes in deaths, again, you look at the countries in this list, mostly very, very poor countries, with a few exceptions like Israel. That's a concern. Israel, the 400% increase in the number of deaths. Again, for a highly vaccinated country, that is hugely concerning and really makes you concerned about what's going to happen in the US. Okay. So it's my observations on death globally. Not much has really changed. As far as vaccines, we're above 4 billion now. About 2.5, 2.2, 2.3 billion people vaccinated with at least one dose. Still have a long ways to go. That's roughly 30% of the global population with at least one dose. Still have a long ways to go. What I want you to notice here on this list is, again, the US is not in the top 25. So the darker number is people fully vaccinated. The lighter number is people with partially vaccinated. So, you have countries where over 70, close to 80% of their population is vaccinated, at least with one dose. Yeah, again, US is not on here. Of concern is countries like the UK here. Again, I mentioned close to 70% vaccinated with at least one dose, yet they're seeing this huge surge. Denmark as well, Iceland, Netherlands saw a surge, Israel seeing a surge, Mongolia. So this is, again, our big concern. Even in countries with high levels of vaccination, we're still seeing surges. Now, again, the caveat here is in most of these countries, particularly those vaccinated with the mRNA vaccines, are not seeing an increase in deaths. They are seeing an increase, but not as bad as in prior surges. So we do know, again, the vaccines may not be as effective against infection, but they're highly effective against serious disease and death. This is the flip side. These are the countries with the lowest levels. And this is an atrocity. This is a human rights atrocity. Haiti is less than 0.1% of its population is vaccinated. Democratic Republic of Congo, Burkina Faso. So these are almost all poor countries in sub-Saharan Africa or Asia. So yeah. These are the countries, again, are going to suffer the most because of Delta. Not even their most at-risk folks are protected. They don't even have enough doses for their healthcare workers. And so this shows Europe, almost 50% of their population, at least one dose. North America, almost 50%. South America, 45%. Asia, about 29%. Oceania, about 25%. And then Africa, maybe 4%. Mostly in the wealthier parts of Africa. For example, South Africa has a fairly high, robust vaccination program. Tunisia and Libya, assisted by France. But the really poor countries, you saw that list. And now you can see by continent, again, Africa's only getting a small proportion of the vaccines. And then low-income countries are getting almost no vaccines. This is, again, I sound like a broken record. This is something we need to address. We need to find a solution for it before the next pandemic. This will hurt everyone. Right now, Africa is just a variant factory. In fact, the unvaccinated in this country are just variant factories. Yeah. So. All right. So those are global numbers. Let's look at the US numbers really quickly. Summarized, not in a good place, but it's going to vary quite a bit by area of the country. So we're definitely seeing a surge. We're now at 100,000 cases per day, which is about the level we were at in February of this year, or about November before this present surge. You can use your, whichever metric you want to use. So not in a good place. Luckily, deaths, we're starting to see an increase in deaths as well. So that's a concern. Hospitalizations are definitely up. But again, this is mostly in the unvaccinated. This is a tale of two pandemics in the US as well. It's very different scenarios for the vaccinated and the unvaccinated. This is by region. This is out of the New York Times. This is a nice little graphic. They decided to break out Louisiana to shame them. I don't know, but it's bad in Louisiana. It's really bad. But you can see there's definitely regional differences. The Northeast is seeing a surge, definitely seeing a surge, but it's not doing nearly as bad as the South. And the West and the Midwest are kind of in the middle. And Louisiana is in a class all its own. I'll show you the Louisiana numbers in a bit. So you can see just like a rash here in the South, in the deep South and Texas, it's starting to spread. It was focused on Missouri, Arkansas, it spread into Louisiana. Texas is now has a really high number. Mississippi, Alabama, Georgia, Florida is really struggling right now. Kentucky's struggling. Tennessee is starting to spread north, which is a little concerning. Northeast state is still relatively quiet. They're seeing increases, but not to the magnitude that they're seeing in the South. The West is also struggling a bit, particularly rural parts of the West. So I need to emphasize it's rural parts of the West that are driving the Western outbreaks. So you can see that in the map here. It's Eastern Oregon, Eastern Washington, Southwestern Oregon. These are very rural parts of those states. Rural parts of California, Utah, Montana, Idaho. Upper Midwest is still relatively quiet. Okay, so these are the numbers by state. Florida, 18,000, almost 2 times that of Texas. Florida's really struggling right now. Their hospitals are just completely getting overwhelmed. Mostly in the rural areas up in the northern part of the Panhandle, outside Jacksonville. I know a lot of folks like to call that South Alabama. Very different area culturally from the rest of the state. I'll show you the Florida map in a second. Texas is now number 2, California is 3. But again, I think a more useful metric is the per capita, ranked by per capita. Louisiana is number 1, Florida is number 2. That's 97 per 100,000, 84 per 100,000. Really, really high numbers. Arkansas, Mississippi, Alabama, Missouri, Oklahoma, Alaska, South Carolina, Texas. Again, mostly in the South. Mostly states with very low vaccination rates. In Louisiana, Mississippi, they have some of the lowest vaccination rates in the country. Texas, Georgia, Tennessee, Kentucky, Nevada. So you can see Hawaii's up in that list too. They're seeing a bit of a surge. Wyoming showed up. Utah's a little bit further down. We'll talk about Utah in a bit. This is the other end. It's the flip side. Mostly states with higher levels of vaccination. 2 exceptions, South Dakota and North Dakota. They seem to be doing okay, even though they have some of the lowest vaccination rates in the country. So far, they're doing okay. But again, Sturgis is coming up. I think it's happening right now. And that concerns me. That concerns me. Okay, there are people from Louisiana, Missouri, Arkansas coming up to all party and be in close quarters. It's a bit concerning. One of the theories behind the Missouri surge was, well, Branson, Missouri. A lot of people vacationing in the Ozarks, Branson, Missouri. And in fact, those counties where a lot of vacationers go, their hospitals were completely overwhelmed. So that is a concern. Same thing happened in Utah, right? Moab. We had a huge surge in Moab earlier this spring when they had all these events in Moab. They're still struggling even now. All right, so yeah, interesting. There are 2 outliers, North Dakota and South Dakota. Outside of those 2 outliers, these are all states with higher levels of vaccination. All right, as far as changes, New Hampshire, Wisconsin. So again, this surge is nationwide. There's no state that did not see an increase. But again, the magnitude of the increase is going to be different depending on whether the state has high levels or low levels of vaccination. The magnitude of the change is going to be much higher in those states with low levels of vaccination. Yes, Vermont has seen a 230% increase, but 230% increase of a handful of cases is still a handful of cases. It's definitely worth keeping an eye on, but it's not in magnitude. It doesn't even pale. It pales in comparison to what's going on in Louisiana. Hospitalizations, Florida is number 1, Texas, California. From a per capita standpoint, Florida and Louisiana lead the way in hospitalizations. They're over capacity right now. Arkansas, Nevada, Missouri, Mississippi, Alabama, Georgia, Texas. Those hospitals are right now completely overwhelmed. By the way, as a side note, it's going to take years for our medical community to recover from this. The burnout is real. And this time around, the surge is largely preventable. So the frustration level is palpable among frontline workers. You know, substance abuse, depression, suicides are all increasing in our medical community. And there's going to be there was already going to be a shortage of medical personnel. And that's just going to be exacerbated by this because a lot of folks are leaving the field. And I think a lot of folks don't want to get into the field. As far as deaths are concerned, Florida, California, Texas, they're leading the way with Louisiana, Missouri, Arkansas. Again, these are with deaths, that's where lack of vaccination is really going to, it's really going to affect deaths. So again, these are, and look at per capita, deaths per capita per 100,000. You look at all those states, Arkansas, Louisiana, Missouri, Mississippi, Nevada, Florida. These are all states with very low levels of vaccination. Okay, remember, the vaccines are most effective at preventing hospitalization and death. So that's where we're really going to see the surges in deaths. I very much doubt, even if we see a surge of cases in places like Vermont or Massachusetts, I doubt we're going to see a huge surge in deaths because of the level of vaccination in those states. Now, even in states like Mississippi, Alabama, you may not see a huge surge in deaths because even though they have very low vaccination rates, their seniors are for the most part vaccinated. So the peaks in deaths aren't going to be as high as before, but it's still going to be a lot more there because there's just simply a lot more unvaccinated folks in those states. In terms of vaccinations, we're now almost 200 million doses, or 200 million people, excuse me, not doses, 200 million with at least one or both doses, okay? So that's about 50% of the entire population fully vaccinated, about 58% with at least one dose. There's some good news on the US vaccination front. There's a slight increase in vaccination rates in recent days because more and more people are realizing, I gotta get vaccinated. Now, keep in mind, vaccination, even if we see a huge surge in vaccinations right now, it's not gonna do much for the short term. Vaccinations will not take, if you get vaccinated today, the vaccine is not going to be fully effective for another 6 to 8 weeks. Dose 1, 4 weeks. Dose 2, another 2 to 3 weeks for full efficacy. So we're not going to see the results of any increase in vaccination until well into September. So it's not going to do much for this present surge. Okay, but of course, we still need to vaccinate to prevent possibly even greater surge in the winter. So there's a slight increase. You've all heard the stories, folks, at their deathbeds, like, I wish I got the vaccine, or pleading with their docs to get the vaccine as they're put on a ventilator. Of course, it's too late for those folks, but even folks who are healthy now, the only way they're going to protect themselves in the short term, isolation, masking, hygiene, so on. Social distancing, so on. So if you look at 18 and up, we finally reach over 70%, which is the goal President Biden set about a month late, but we reached 70%. Fully vaccinated is about 60% of 18 and up. The good news is 65 and up, the vaccination rates are much better, which was a concern because of the political split in vaccination. So it's nice to see that, our senior, the most vulnerable population, the vaccination rates are high, regardless of political positions. So that's really good to see. The concern right now is young people. The young people are what's driving hesitancy right now. So this is what I mentioned. This is good news. We were down to about 500 doses a day, which is not great. We're now up to close to 700,000 doses a day. So we've seen a slight uptick. Supply is no longer an issue in the state in the country, of course. In fact, a whole bunch of vaccines are about to expire. We're probably going to end up throwing them away, which is, I can't tell you how the level of tragedy that is, given that there are folks literally dying for vaccines in the global South. As far as states this is a great I love this graphic because it tells you at the current pace when they're going to achieve 70% of adults vaccinated. So these are the states in this corner here. Those are the states that have actually reached that point already or close to it. And this is the projected date that these states are going to reach that point. West Virginia may not reach it until 2023 at this rate. Wyoming, not till 2022, late night 2022. Idaho, 2022. North Dakota, 2022. I would argue those states may never reach 70% if current trends continue. And that is a level of frustration that I think we in public health just like doctors who know that this surge is different because it's largely preventable. Hospitalizations are largely preventable by vaccinating. It's frustrating on so many levels. States that have done a good job, of course, the New England Northeast, the West Coast, and the Upper Midwest, with a few exceptions. New Mexico's done a phenomenal job. The South, boy, not great. You can see that Idaho, Wyoming, Louisiana, and Mississippi have the 4 lowest vaccination rates, and I'll show you the details. You can see, again, focus in the Southeast, lack of vaccination. The darker the color, this is by county. Darker the color, the more folks in that county are vaccinated. So you can see that it's largely a rural phenomenon. Vaccine hesitancy is largely rural, largely southern. And of course, you overlay this map with the election map from last election, it's going to be almost perfect match, unfortunately. And yes, it has been, the politicization of COVID has been another point of huge frustration. By state, Hawaii leads the way in terms of the 18 to 64. They're a little bit behind on the 12 to 17, but not too bad. Then Vermont, Massachusetts. So these are states that have some really high levels of vaccination, even higher than the UK. So we may not see a surge in those states. So that's good news. Again, mostly in the Northeast, West Coast, Upper Midwest. Then you see Utah here. It's not doing as bad as people think. Again, when we look at percentage of total population vaccinated, people need to realize that a much larger proportion of our population is ineligible for the vaccine because they are under the age of 12. We are the youngest state in the country by far. Once you adjust for that, we're not doing terrible. Could we do better? Of course, but we're not doing terrible. We're down there with Delaware. There, that's a bragging point. Yeah, we're right there with Delaware on vaccination. But it could be worse. We could be down there with Wyoming and Mississippi. Yeah. Mississippi, that has 44% of its population 18 to 64 vaccinated. Only 21% of their 12 to 17. You look at the difference between Mississippi and Hawaii, and it's just extraordinary. It's a twofold difference, more than twofold difference. Wyoming. Idaho's not great. Louisiana, Alabama, West Virginia, Tennessee, South Carolina, North. So you can see very much a political split as well, unfortunately. Right, this is where the highest risks are right now, the Southeast. Parts of Utah and Nevada. But really, it's the Southeast. Safest place right now, the Northeast, particularly rural parts of the Northeast, and the Upper Midwest. So here's Florida. Florida's numbers are now exceeded the peak that they suffered through this last winter. So you can see it's mostly in the Panhandle and the Northeast over by Jacksonville. Missouri, not quite as bad as the winter. But my guess is that these states will exceed their peaks. They will break records. Arkansas, really close. I think they will break a record as well. Louisiana is already higher than their previous peak, and it's showing no signs of letting up. They had over 10,000 cases. So same with Alabama. Again, those graphs are going straight up. Alabama, Mississippi's already exceeded it. You can see the new cases there. Texas is heading there as well. These are also states where governors are being very resistant to COVID restrictions. So many of these states have bans on mask mandates, bans on vaccine mandates. Now there are a few governors that have relented. For example, Asa Hutchinson, the governor of Arkansas, said he regrets signing the bill that banned mask mandates. Governor Hutchinson of Mississippi, some other Hutchinson, two Hutchinsons, basically just flat out threw the unvaccinated folks under the bus, saying, this is all your fault. So maybe there's some second thoughts. I think, in the face of filled hospitals and dying constituents, maybe political reality sets in. I don't know. It'll be interesting. Yeah, vaccination doesn't capture tourism. Yeah, thank you, JC. Yeah, again, tourism is going to be a large driver for these surges. I mean, tourism and these super spreading events, whether that is Sturgis or Euro Cup or Olympics, or everybody visiting Hawaii, Branson, Georgia. Again, they're heading up. I just want to show a few states that are doing well. Vermont. So Vermont, yeah, they're seeing a surge, definitely. But I mean, you look at their per capita rates. You look at these numbers. It's definitely a surge, but it's not going to be to the degree that it is in the South. One thing that the UK and Israel is showing us is that even in areas with high levels of vaccination, we're going to see surges because, well, Delta is far more transmissible. And the vaccines are not quite as effective against them. We'll go over that in a second. Minnesota as well, they're seeing a little bit of a surge, but again, not to the degree that you're seeing in say, Louisiana. Pennsylvania, yeah, you're definitely seeing an increase. But again, not to the degree that you're seeing in these other states. So, here are my observations about the US. We're not in a good place, particularly in the South. It's getting bad. And what's really unfortunate is that these are also areas with the most resistant towards any sort of mitigation strategies that can blunt this surge. And that's the biggest frustration. Right now, vaccinations, yes, we need to vaccinate, but it's not going to do anything about these current surges. What will do it, the only solutions that these states have, masks, social distancing, restrictions, but these are also ones that are politically almost a non-starter in these states. So my fear is that these surges will get far worse before they get better, especially in the South. Not so concerned about the Northeast and Upper Midwest. California, yeah, they're seeing a surge, but again, they're not quite as resistant to the public health tools that we have. Utah, we're seeing a surge, but it's not quite as significant as some of these other states. Now, it could be because we have a higher level of vaccination, as I've shown, particularly among those over the age of 18, but also our major population centers are fairly highly vaccinated, and most of the surge is happening in rural areas. And of course, I mean, rural areas, there just simply aren't as many people, especially in Utah, in rural areas. So it's really, you're seeing a surge, but it's not the horrific, straight up graphs that you see in some of these other states. I mean, it's definitely real. Hospitalizations are definitely peaking. Talk to Mount Healthcare, University of Utah, their ICUs are getting filled up. Their hospitals are getting back into that COVID footing. It's happening. It's definitely happening. So again, Salt Lake, of course, is number one. Utah County, Davis Weber. But again, a better metric is per capita. And if you look at it per capita, Salt Lake it's kind of middle of the way. So about 27 per 100,000. Duchesne is 44. Wasatch is seeing a surge. Iron County, Juab County, Uinta County, Wayne County. Among the Wasatch Front counties, Utah County is doing the worst, followed by Weber County, and then Salt Lake and Davis. That's going to be a trend that we're going to see often because Utah County, of course, has the lowest levels of vaccination as well. Now, there's a lot of instability with the numbers in rural Utah County because, well, there's just, those of you in the East Coast, you haven't, I grew up in Massachusetts, and it's a lot of people in Massachusetts, everywhere. So once you don't really understand how sparsely populated the Mountain West is until you actually live here and travel through it, and you realize, holy cow, this giant county that's twice the size of Massachusetts has only about 5,000 people in it. It's kind of nutty. But anyways, so there's a lot of instability in the numbers. But again, the surge is largely driven by rural Utah and Utah County. Okay, so hospitalizations, you can see, again, Washington County, number 1, Kane County, Iron County. So the hospitalization rates, the other problem with the hospitalization rates being so high in these counties is that they lack hospitals. We just don't have a lot of rural hospitals. Rural hospitals actually been closing because they're not profitable. Again, product of a for-profit healthcare system. So, when Kane County or Iron County has this many hospitalizations, it's pretty serious. Okay, Salt Lake County, like I said, is kind of middle of the way. Utah County actually has a lower hospitalization, mainly because it's such a young population too. Utah County is one of the youngest counties in the youngest state in the country. So yeah, lots of kids in Utah County. As far as deaths per capita, Kane, Millard, Carbon, Box Elder, San Pete, Uinta, Weber, Washington. So again, Salt Lake County is fairly low down in deaths. Why? Probably because of vaccination. That and just access to better healthcare. Because most of the major healthcare institutions in Utah along the Wasatch Front, particularly in Salt Lake Valley. So that is our test positivity. Not great. This is test over test, and is over 10%. We're seeing an increase of testing, so that's good. Hospitalizations, like I mentioned, it is increasing. Gosh, with the smoke we have today, I feel for those folks with COVID symptoms right now. It's got to be really, really bad. I know. Those of you who are in Utah, air's kind of chewy right now. It smells like a really bad barbecue. You can smell the smoke, and it actually hurts my throat. So it's really bad. A cold front brought all the smoke from Oregon and California straight to Utah. So anyways, that is really, really bad for people who have respiratory distress because of COVID. I'm hoping that we don't see a spike in mortality because of that, but we may. So deaths, though, have stayed fairly low. We'll probably see a little bit of an increase later on. Again, deaths are a lagging indicator. It's going to lag cases by at least a month. So we may not see a surge in deaths for another month or so, another 2 weeks at least. This just shows you the percentage of variants. It's all Delta now. It's just about all Delta in Utah. And I think the rest of the country, we can just assume that Delta is the main driver of the surge, and you can see that. And it's amazing how quickly Delta took over and how much of an advantage, evolutionary advantage it is to be able to transmit to 2 times as many hosts as the previous Alpha variant. It's a huge evolutionary advantage. Alpha is not even a player anymore. It's all Delta all the time now. As far as vaccinations, we also have seen a slight uptick in vaccinations. So right now, over the age of 12, about 65% of the population over the age of 12 has at least 1 dose, and 58% are fully vaccinated. My biggest concern right now is the 12 to 15. The uptake of vaccines in that population is still fairly low. Unfortunately, they're also heading to school. And that's the biggest fear I have right now in terms of the US. An Arkansas school district, on the first day, they had several hundred students isolated, several hundred students and staff isolated on the first day of school. Yeah. So, and then of course, in the state of Utah, mask mandates have been pretty much banned by the state legislature, like a lot of other Republican states. So that's one of my biggest concerns right now. And this is this, again, a population that is largely unprotected because under the age of 12, vaccines aren't approved. And 12 to 15, parents are just reluctant to get them vaccinated, unfortunately. So again, I see a slight uptick in vaccinations in the last few weeks. But again, I'd like to see it a little bit higher. Again, this isn't going to do much for the current surge, but long term, if we're going to get past this, really vaccination is the only way we're going to get through this. So you can see the variations. Summit County, fully vaccinated, 68%. So Park City in particular is really, really high. Juab County, lowest at 25%. And again, it's just shocking the disparity. Now, could some of that be accessibility? Yes, rural Utah, it's a little bit harder to get a vaccine in Juab County than it is in, say, Sugar House. But still doesn't explain the level of disparity. And this is by small area. So small area, not just county, but Utah small areas is 99 small areas with roughly the equal population. And I've kind of highlighted the Wasatch Front. So you can see definitely a socioeconomic disparity here. So that dark area is Park City, which is relatively wealthy. This, of course, is all the East Bench of Salt Lake City, the Salt Lake Valley. That has the highest level of vaccination. The West Side, of course, mostly more people of color, lower socioeconomic status, lower levels. Utah County is Utah County. Vaccination uptake in Utah County is just really, really, really low. In fact, I was reading an article today, even among BYU athletes, they estimate only 25 to 30% of them are vaccinated. Yeah. So anyways, Utah County, culturally, very different place, living kind of between the two counties. It's pretty obvious to me. I go to the Home Depot in Sandy, about 50% of folks will wear masks. Go to the Lehigh Home Depot, I'm the only one wearing a mask. Anecdotal, yes. But anybody who understands it would agree with me. All right, so, what's, again, really where we need to focus is on young people. They're the ones that are just being reluctant. You can see there's a slight uptick in 12 to 18, so that's good news. So maybe, parents are realizing my kids go to school, I want to keep them safe. But these groups here, the 19 to 29 and 30 to 39, they're the ones that are really the most resistant for various reasons. Racially, we're still struggling in this state. You can see that, this is white, and you can see that there's been a nice increase in the Hispanic Latinx population, but otherwise we are just struggling with this. And this is, again, something that we need to increase outreach for. We need to get creative with getting people vaccinated. I know the right-wing media was just hammered President Biden on his suggestion that we should go door to door, but this is something that we've always done in public health. During our smallpox eradication campaign decades ago, we went literally door to door. And no, they didn't steal guns, they didn't steal Bibles. They just asked folks politely if they wanted a vaccine. And if they did, they administered. If they didn't, then they said, well, thank you very much, and they left. So we need to get more outreach like that. In terms of breakthrough, I'm going to get into this a little bit, and this session is probably going to go a little bit over 90 minutes, so I apologize for that, because I have a lot of information this time around. And I might actually, if I run out of time, I might make another video and just put it online to kind of explain these studies, because I think it's really important. We're definitely seeing breakthrough infections or breakthrough disease. What's the difference? Talk about that. So I love how the state of Utah has presented breakthroughs. I've kind of looked at other states' data interfaces, even Massachusetts, which is supposed to be really good. And this is, to me, kudos to the Utah Department of Health for presenting this so clearly. So this green is the 7-day case rate per 100,000 population for cases among fully vaccinated. The orange is among the unvaccinated, and the blue is total. So you can see very clearly the difference between the vaccinated and unvaccinated. Now, as more people get vaccinated, it's gonna appear that there's gonna be more breakout infections. Okay, so that's something that we have to get used to. And actually, maybe explaining these studies will better explain this. Okay, so here's our Utah observations. Okay, hospitalizations are increasing, deaths are still low. Probably won't be as high as before, but they will get higher. There's definitely a slow increase, so not quite as bad as some other states. There's definitely a correlation between vaccinations and new cases. So let's talk about, so we all know the CDC's new recommendations. Why did they make these recommendations? Why did they say unvaccinated folks don't have to mask to all folks should mask regardless of vaccination status indoors? There's a few things. And so, by the way, only in states that have substantial or high levels of transmission. By the way, Utah is in high, so we should be masking. So why did they make this decision? So I'm not going to go through the entire slideshow. I did that last week. But there's a few things. Number one is that people who are in nursing homes, seniors, immunocompromised, are still at risk for disease, even if they're vaccinated. So that makes sense. If you're in a nursing home, you are at an advanced age, your immune system isn't quite as robust. Even if you're vaccinated, and they still work phenomenally in seniors, you're still at risk. Okay, so folks who are immunocompromised, and that's a big portion of the population. People who have cancer, people who have autoimmune disorders, people who have HIV, people who are in chemotherapy. There's a lot of folks who are immunocompromised. They're still at high risk. But the main driver for the decision was a study, and let me skip over to this. Well, number one is that Delta is probably 2 times more transmissible than Alpha. So the R naught is roughly 2 times. Okay, I'm going to skip over because we're running out of time. I'll go over this next week. So this is the Kaiser Foundation's COVID vaccine monitor. It goes over attitudes towards vaccination. I'm going to go over this next week. So I apologize for not going over it this week. I want to get to these studies. I'll go over those next week. So one of the drivers, the main driver was the fact that they discovered people who are even fully vaccinated are just as transmissible if they get a breakthrough infection as if they're unvaccinated. And they discovered this in this outbreak investigation in Provincetown, Massachusetts. Those of you I'm from the East Coast, I grew up in Massachusetts. Provincetown's right at the edge of Cape Cod. If this is Cape Cod, literally, Cape Cod looks like this. It's at the tip, and every summer it becomes a vacation hotspot. Now, this event in particular was mostly young men, young gay men, and it's a huge festival and party with really high potential for super spreading, similar to Eurocup, similar to Sturgis, similar to Branson, Missouri. And that's what happened. However, this population tends to have much higher vaccination rates than, say, Branson or Sturgis. And so because of that, there was a large number of breakthrough infections. Okay, so here's the summary. There were 469 COVID-19 cases. 74% of those 469 were in fully vaccinated persons. And Delta was responsible for most of them. Furthermore, the cycle threshold values, that's a technical term. Just to summarize this, though, it's a term that comes from the PCR process, the testing process. And the cycle threshold tells you, well, I don't want to get technical. Bottom line is the lower the cycle threshold, the higher the viral load. So if you have lower cycle thresholds, that means the viruses in the test sample are much higher, meaning your viral load is much higher. So what they discovered was the cycle threshold for the vaccinated positives and the unvaccinated positives were roughly equal. So what they're saying is that the potential for infecting people, even if you're fully vaccinated and you have a breakthrough infection, the potential for spreading is just as high as if you were unvaccinated. So basically, it said that people with breakthrough infections could spread the disease. Okay. I kind of suspected this all along. To me, the key issue was, okay, well, that's fine, but how many breakthrough infections are there? Well, in this situation, yes, 74%, that seems like a lot. That seems like a lot of breakthrough infections. I mean, 74% of all cases were breakthrough. They were fully vaccinated. There's some issues with that, though. That's a good question, Kirsten. That's an assumption we make. Higher the viral load, the greater the transmission probability. We know this with a lot of other viral diseases. HIV is notorious for that. Viral load equates to transmission probability. With COVID, with SARS-CoV-2, the theory is that, well, the cells in our nasal cavity all express ACE2 receptors. Same with cells in our lower respiratory system. Now, if you get infection in the upper respiratory system, you get sniffles, maybe sneezing, coughing, usually not serious. In the lower respiratory system, that's when you get pneumonia and death. The theory is that the vaccines may not react quickly. The immune response from the vaccines may not react quickly to the virus replicating and infecting the nasal cavity, but it prevents it from getting down into the lower respiratory system, thus preventing serious disease and death. But if it's in the nasal cavity, it's also the main point of shedding. Probably some validity to that theory, and that's why the vaccines are so effective at preventing serious symptoms, hospitalizations and death, but may not be as effective at creating sterilizing immunity, meaning that you are still infected and can spread the disease. So anyways, this study showed that, oh, crap. And that was the biggest concern, the fact that maybe we're getting, but again, this is really, really misleading. There's a lot of biases here because what's really important is to really determine how effective a vaccine is, you have to measure the number of breakthrough infections over everyone who's vaccinated. That should be the denominator. Here, they don't have that denominator. And in populations where you have a lot of vaccinated people and very few unvaccinated people, yes, breakthrough infections are going to outnumber the regular infections, sometimes by a significant amount. I think that's what's happening here. This is a largely vaccinated population. So yeah, even if breakthrough infections are a small proportion of all infections in the larger population, when you have a subpopulation that's largely vaccinated, it's going to inflate that number. I'll show you an example of that in a second. The other thing that so here is the cases and their vaccination status. So the fully vaccinated is lighter color, and the non-vaccinated is a darker color. Again, we don't know within this entire outbreak and these gatherings, what proportion of folks were vaccinated, what proportion of folks were unvaccinated. But if you have 1,000 people and 900 people were vaccinated, 100 people weren't vaccinated, yeah, even if breakthrough infections are small, is rare, the total number when compared to the non-breakthrough infections might seem artificially big. And that's the problem with a lot of headlines I see with breakthrough infections. It's like, wedding, everybody was vaccinated. All of them were breakthrough infections. There's five breakthrough infections. Well, of course they're all going to be breakthrough infections because they were all vaccinated. The real question is, okay, what if there were unvaccinated folks? What if all those folks were unvaccinated? You could have probably gotten 50 or 60 infection cases instead of just 5. No one thinks that way. They just see, oh my God, wedding, everybody was vaccinated. There were 5 breakthrough cases. Anyways, that's just math too. The other thing that they found was, again, cycle threshold was the same. So there's a vaccinated, unvaccinated. Notice the numbers. These are pretty small. 84 unvaccinated and 127 fully vaccinated. And you can see, that's cycle threshold, meaning that the viral load is equal at that point in time. Thank you, Kirsten. I'm going to look at that actually. Yeah, because the denominator is really important. I know it sounds epi-nerdy stuff and kind of is epi-nerdy. And I have lots of materials to cover in my epi class this coming semester. So anybody's welcome to sit in on that. Okay, now, so that's a province out. Now, I don't want to criticize the CDC, and you know what's coming next. But if that's the only data point that they use to implement mask, to do this 180-degree change in mask policy, now I tend to agree with their mask policy. I don't, quite honestly, a lot of us think we should have never gotten rid of the mask mandate at all. I know why they did it, to encourage people to get vaccinated, to give people who are vaccinated at least, hey, yeah, you should get vaccinated because you don't have to wear masks. Because a lot of folks are saying, well, if I have to still wear a mask, why the hell should I get vaccinated? So they want to give incentives. I know why they did it, but anyways, if that's the only data point, I got an issue with that because more data is coming out. That was really, to me, incomplete. Without that denominator data, how many actually people were there at that entire party, that entire event? What proportion of them were vaccinated? So to get to, that was the best way to really determine how effective vaccines are. Just looking at the cases, it's like comparing, the number, just looking at counts, looking at the number of breast cancer cases in Salt Lake City versus the number of breast cancer cases in Beaver, Utah. Beaver is a much smaller city. Of course, there's going to be fewer number of breast cancer cases in Beaver because it's a smaller city. They're apples to oranges comparison. This is kind of the same, right? Now, there's few other data points that came out. To me, far more reliable. This study is called the REACT study. This is round 13. The UK has some of the best data on COVID right now because of NHS, socialized medicine. It makes for really good public health data. So they have really good data. So this REACT is basically they randomly survey 20, 30,000 people each round and have them submit a questionnaire, whether you're vaccinated, socioeconomic status, et cetera, and then submit a nasal swab to do a PCR test on it. So they usually get about 20, 30,000 people per round. So they just published round 13. This is during the meat of the surge in Delta. Okay, so this is infection, by the way. They are looking at infection because they are asking everyone to submit a swab. So not necessarily symptomatic disease, but infection. And we don't really have a lot of analyses of how good the vaccines are against infection. We have some good data on the efficacy versus disease, but not on infection, unless you do something like this. Israel has also done this. And the UK has. So this is round 13. So So linked is, this is the more reliable, the linked part. Linked means they ask you, have you gotten the vaccine or not? And they try to follow that up by linking their records to the NHS, because nationalized data set, to determine if they've actually gotten the vaccine. So the linked one is a little bit more reliable. So you can see you can see the odds ratios. Well, let me explain the odds ratio. So basically, this is all, so everyone, all ages. So the vaccinated, greater than 14 days second dose, you're about 1/4 times more likely. You're actually, let's put it this way: unvaccinated are about 4 times more likely to be positive than the vaccinated. Okay, so fourfold increase in risk for those who are unvaccinated versus vaccinated greater than 14 days after dose 2. Okay, about equal in the 18 to 64 category. Okay, so this is infection with Delta. So again, 4 times more likely. Okay, what does that equate to in efficacy? Well, if it is about 61 or 62%. So that doesn't seem very high. And it definitely isn't as high as the 90% that Pfizer published for the original wild type variant. What, 61, 62%? That's not very high. But remember, this is for infection. The 95% that was published by Pfizer against a different variant was against symptomatic disease. If you look at symptomatic disease, it's actually much higher. The efficacy against Delta is much higher. This is for infection. So before you freak out and say, oh my God, it's only 61, 62% effective. Remember, this is for infection. Okay. That's why I went over that, all that stuff. Now, back to that. So that's coming out of the UK, and this is really reliable data. So yes, there is a degradation in efficacy against infection towards Delta. Okay, so it's not quite as effective at preventing infection, which means if you're infected, you can spread the disease, and thus the mask mandate. Okay. It's still effective. 61, 62% is still effective. And against, again, symptomatic disease, it's far more. That's in the mid 80s. So that's far more effective. But even against infection, it is very effective. But it also means that a fair number of breakthrough infections do occur, probably far greater numbers than we know. And those breakthrough infections have the potential to spread it. Now, I think that even breakthrough infections are less likely to spread it than non-breakthrough infections. And I have some data to show that as well. Now, you're probably saying, well, that Barnstable study showed that viral load's the same between vaccinated and unvaccinated. Well, there's other factors here. Like Kristen mentioned, there's other factors here play. Okay, and I'll show you the data in a second. But here, back to that point about, okay, you can't compare the number of breakthrough cases versus non-breakthrough cases in the Provincetown outbreak without looking at the total populations of vaccinated and unvaccinated. Case in point, here is round 13. Here is the number of positive cases, 65 or over, in the non-vaccinated group. 0 cases of COVID in the non-vaccinated group of over the age of 65. 28 breakthrough cases in those vaccinated with 2 doses. Oh my gosh, the vaccines are totally worthless. All the cases were in the vaccinated group. Until you look at the total numbers. Not vaccinated group over the age of 65 in the sample, 423. Vaccinated group, 11,792. Yeah, so that's why you just can't look at these numbers. Oh my God, 0 cases among the unvaccinated, 28 cases among those vaccinated. Vaccines are totally worthless. In fact, it maybe causes COVID. You got to look at the denominator. There's only 423 people in this population that weren't vaccinated, whereas close to 12,000 had a full 2 doses of vaccines. Cannot compare those two. And to me, that's why these headlines are so misleading. The other issue with this is that a lot of these populations, so, I like to use the New York Yankees example because I'm from Boston and I hate the Yankees, but at the same time, it's a good illustrative example. So they made a lot of headlines because they can't seem to keep healthy from COVID. I mean, yeah, because they keep getting breakthrough infections. But here's the thing. Athletes, politicians are tested far more frequently than regular folks, even if they're vaccinated. That's just a protocol. If someone, for example, if someone in the Yankees test positive, that means everybody, regardless of whether they're vaccinated are tested. So there's a much greater chance of detecting breakthrough infections, not necessarily diseases. And in fact, I don't think any of the Yankees had breakthrough disease. None of them showed symptoms. They were all asymptomatic. So you have to keep in mind when you hear about breakthroughs, the context. Okay, anyways, so that's kind of what I want to show you. The other thing I want to show you is CT values. So the UK did CT values on a far greater number of samples. And what they found was that those who were vaccinated had slightly lower CT values, slightly higher CT values than those who were unvaccinated, meaning their viral loads were significantly lower. So you look at this right here, all data. So you can see that the median CT values between not vaccinated and 2 doses of vaccine, and that's a significant difference. So the 2 vaccine doses, it's higher CT value, which means lower viral load. So they're showing something a bit different than the Provincetown data. This is how EPI works. We need to refrain from acting on one data point, and we need multiple data points, preferably from different settings. We're finally starting to get that. So this is showing something very different than the Provincetown. This shows that no, vaccinated folks actually have lower viral loads. Now, this could be explained because in Provincetown, I believe everyone was symptomatic. All the cases were symptomatic. This is all infection. So these are all asymptomatic. But anyways, yeah, so perhaps we got a little too worried about the Barnstable County study, and we should have waited until we got more data. I don't know. I'm not, as far as public health policy, I'm always a fan of doing too much more than too little. I know politically there's a cost to that, but I sleep better at night knowing that I did a little bit more than not enough. So in that sense, I think this is okay. Another study, this is out of Singapore. And they looked at duration so this was a study. They found that the vaccinated group is I believe they were, one sec. The heck is my, there it is. The unvaccinated are 14 times more likely to be hospitalized to have serious symptoms than the vaccinated. That equates to about a 93% effectiveness. Okay, so that's good news. But the other news out of this study is the red is CT value over days of illness. So about a 4-week period, 28 days. The red is unvaccinated. The green is vaccinated, breakthrough cases. You can see that the CT value increases in the vaccine breakthrough cases. So the duration of infection for unvaccinated is much greater than duration of infection for vaccinated. So we're getting different stories here. Now, the Barnstable County study did not look at duration. So this is the first study I've seen that showed breakthrough infections versus unvaccinated and showing that the breakthrough infections have a much shorter duration of infection. So folks who are vaccinated, even if they are breakthrough infections, even if they're shedding viruses, they only do so for a much shorter time than those who are unvaccinated. finally, one other study I want to share with you. This was a case control study out of the UK. So case control study is the UK has data. I mean, they have so much good data because of their nationalized healthcare system, the NHS. It's an epidemiologist dream. I always joke around with my colleagues in England saying that epi is way easier for y'all than it is for us because we have to deal with this fragmented excuse for a healthcare system and health data system while you have all your data in one database. What's the challenge in that? But anyways, the advantage is you get some really good data. So they did a case control study. So they find a bunch of folks who are test negative and then a bunch of folks who are test positive. Okay, and that's all nationalized. It's all in the data set. And then compare their vaccination. Okay, and then you can determine efficacy based on case control. So what they found was, dose 1 and 2, they just found that vaccine efficacy is, and I believe, again, this was infection, not disease. And they found that the vaccine efficacy, any vaccine is about 80%, but with the Pfizer vaccine is about 88%. And with the AstraZeneca, it's about 67%. So again, we got data showing 88%. We got data showing 61%. Which one to believe? Now that 61% from the previous study, the REACT study, was both of AstraZeneca and Pfizer. They didn't differentiate the two. And you can see that the efficacy of the two are fairly different. So that's one explanation for that. But again, this is the point in epidemiology. We can't rely on just one study. In fact, that's a cardinal rule for causality. When can we say something causes something? Well, when you have a fair number of studies that kind of should say the same thing. Basing everything off of one study is dangerous. And this is why you need to look at other studies. So all these studies are telling us slightly different things and giving us a little bit more insight into this entire question as to, number one, breakthrough cases versus non-breakthrough cases. Transmission, what are some of the transmission dynamics? And number two, how effective is the vaccine at preventing infection and preventing disease? We're starting to see that more. So bottom line is that it seems to me that yes, vaccinated breakthrough cases, yes, it looks like about a 60 to 70% effectiveness against breakthrough. So we're getting more breakthrough infections. And breakthrough infections can spread the disease, but not as well and not as long. Number two, these vaccines are still, even if it's 60% effective against, 60, 70% effective against infection, they're much more effective against hospitalization, probably mid 80s to 90%. So again, the bulk of their work is between infection and disease. They're extraordinarily good at preventing infections from progressing to disease, and from disease to progressing to serious disease and death. That's what this data is showing. Vaccines are still highly effective. Okay, but again, there's going to be different degrees of effectiveness based on whether you're looking for infection, disease, serious disease, and death. Okay, and that even if they are breakthrough infections, there is the possibility of transmitting the disease, but it's not as bad as what that original study says. That was a lot. That was a ton of stuff thrown out there. Hopefully it was a little bit more helpful. I might put in another video explaining some of these studies, because I think these 4 studies are really important, and more studies will be coming out soon to hopefully clarify this. But ever since that decision was made on that CDC study, more data, the REACT study, round 13 just came out. It's still pre-publication. So they have, that just came out. This case control study just came out. The study out of Singapore just came out. So you are all on the cutting edge of looking at studies, by the way, that aren't even peer reviewed. Those will be peer reviewed and approved because they're good studies. But that's where we're at with this whole question with breakthrough infections, breakthrough disease, vaccine efficacy versus each of those, transmission among breakthrough infections versus non-breakthrough infections. That's the latest data we have. Again, like I said, vaccines are still effective. They're not as effective against infection, still really effective against disease, and really, really effective against serious disease and death. Transmission can occur in breakthrough infections. And the danger of that is that a lot of them are going to be undetected. You and I, maybe we are shedding virus. I don't know, because that's what the vaccine does. It prevents serious disease. So we might just be infected, but still shedding virus. But we're going to be shedding less virus, okay? And we're going to be shedding virus for a shorter period of time. But I think it's still, one could say this still rationalizes the CDC's decision on masking. And again, like I said, I know some people think that it's like the ultimate infringement on people's personal freedoms. I disagree. It's a piece of cloth over my face. It's uncomfortable, yeah. Can people see my, sneering smile? No. But really, it's not bad. And I'd much rather, like I said, I'd much rather overreact than underreact. So I think the CDC's move is actually valid. I think it's good, at least until the overall numbers go down. Okay. By the way, today's lecture is going to be, it's on Facebook Live. I haven't even checked my Facebook feed. I apologize. I'm in my office, actually. I'm not at home. So this is my office. Yeah. And it will be on my Facebook feed and Facebook Live. Also, it is uploaded onto my YouTube page. It's called No, I Won't Look at Your Mole. That's an inside public health epidemiology joke. Let me find that link and I'll put it up in the chat for you if you want to check that out too. So that has I started putting up stuff in the last 2 months. So it has some of the older lectures, but really, I mean, you could look at the older lectures, but this is changing so quickly that you might just want to look at the more recent ones. So, okay. So yeah, that's how I share it. And again, I will be back next Friday because there's going to be more news. Every time I think I'm going to wind down my brown bags, it just ramps up. Or I'm going to make it 15 minutes long and it ends up being a 2-hour lecture. So, all right. But thank you very much for attending. Like I said, same link if you're interested in next week. I'm sure there's a whole bunch of other stuff I'll go over next week. Noon, Mountain Daylight Time, excuse me. And yeah, like I said, if you miss it, it's going to be on Facebook as well as on YouTube. So thanks very much. I appreciate your attendance. I appreciate your time. And yeah, I'll be back next week.